the Shonga Clinic in Kwara State. That's the first PHC I went into. And when I went in there, I went with then Minister of Health, I forget her name. When we went in there were goats running around. Goats. Yes. Pregnant goats. Those goats are always pregnant. Pregnant goats, grass everywhere. And within 2 months, the utilization went from 0 to over 5,000 a month.
Wow. Hello, healthcare enthusiasts, and welcome back to The Cure. This is the podcast where we're revolutionizing the business of healthcare in Africa, one conversation at a time. I'm your host, Temitope Koka, and in each episode, I sit down with the people shaping the future of healthcare in Africa, from founders to investors to policymakers and beyond. And our goal is very simple: to infuse hope back into the narrative by spotlighting the momentum and the progress that's already unfolding across the continent. And at the heart of every episode is one key question: what does it take to revolutionize the business model in African healthcare? All our insights are powered by TC Health, your trusted source for healthcare and pharmaceutical insights in sub-Saharan Africa. So let's get into today's episode. We are in season 2, and I'm very excited because we are exploring a new theme. So our season 1 theme was By Africa for Africa. So we were exploring what does it take for Africans to build innovations fit for purpose for Africa. But now in season 2, we're exploring what does it take to build the rails? So the regulation, the financing, the partnerships, the infrastructure that turn a promising idea into reliable healthcare, into universal health coverage. And today's conversation sits right at the center of that theme. Here's a reality that a lot of people often overlook. The private sector provides and delivers about 60 to 70% of all healthcare in Nigeria. So that's private hospitals, pharmacies, clinics, diagnostics labs, HMOs. They're often the first and the only, in some cases, point of care for millions and millions of Nigerians. But the relationship between the private sector and the public system, while progressing in so many meaningful ways, can sometimes still be marked by fragmentation, mistrust, some missed opportunities. And so that's where public-private partnerships come in. And people talk about PPPs all the time. PPPs have become this kind of buzzword in global health, in African healthcare. Everyone agrees that PPPs are important. I don't think there's any debate that PPPs are unimportant. But when you look at the track record, the number of PPPs that have actually scaled beyond maybe a pilot phase, etc., that have fundamentally shifted how care is delivered on the continent, that list, while incredible, can feel a bit short. So today, we're going to unpack what it actually takes to make partnerships between governments and the private sector work in practice and in reality. And my guest today is someone who has been at the intersection of this work for over 25 years. So I'm going to introduce Mrs. Njide Ndili. I'm going to go into a lot of your background, so you might blush. But Mrs. Njide Ndili is the president of the Healthcare Federation of Nigeria, the largest coalition of private healthcare stakeholders in the country. HFN represents everyone from hospital groups and HMOs to diagnostics companies, medical device companies, pharmaceutical manufacturers, all united under this belief, under this umbrella that Nigeria can't reach universal health coverage without activating the private sector. By day, Mrs. Ndili also serves as the country director for PharmAccess Foundation in Nigeria, an international NGO that has been on the ground for years, actually building practical PPP models, which I'm really excited to unpack today, all across the country, from health insurance in Lagos to also work in Ghana as well.
Yep, and Tanzania and Kenya. Yes.
So these are the things we're going to jump into today. We've also seen quality improvement through safe care, which we're going to dive into, revitalizing primary healthcare centers all across through PPPs. She was also the commissioner for the Lancet and Financial Times Commission on Digital Health and AI, a commission which ran from October 2019 to December 2021.
That's correct.
And explored the impact of digital health, AI, and other kind of technologies on the frontier on universal health coverage, which is everyone's talking about AI, everyone's talking about digital health. And she was a founding member of the Digital Transformation for Health Lab, which identifies technologies that accelerate universal health coverage, particularly for low and middle income countries.
And young people.
Who are the vast majority of our audience.
And digital natives use the technologies, which is why it's very important.
Yes. Yeah. And we talked about this in our episode 5, I believe, of our last season with Michael Famarotti. So he's one of the co-founders of Steers. Okay. And they gather financial data all across the continent. And we were introducing this idea that because of how many young people there are in Africa, like our population is predominantly young, predominantly under the age of 18. And the youth are incredibly digitally native. Like we grew up with technology that creates this tipping point, this breeding ground for innovation and all of the ways that we can accelerate universal health coverage, health tech to really get us there, because now you're looking at a population that is tech first. So that's a really interesting development, which ties really well. And then lastly, you sit on the steering committee of the Nigerian Economic Summit Group, Health Policy Commission. I love introducing my guests because it gives me so much joy to be able to actually speak to people with so much rich experience. So Njide, welcome to The Cure.
Thank you. It's amazing to be here.
Mm-hmm. Thank you. So before we dive in, I want to share something very exciting. The Cure is partnering with the World Health Expo Lagos, West Africa's leading medical trade event that's taking place from the 2nd to the 4th of June 2026 at the Landmark Center in Lagos. WHX brings together over 500 exhibitors, 8,000 healthcare professionals, and 30 world-renowned speakers across medical devices, diagnostics, healthcare infrastructure, digital health, the list goes on. This year's Hospital Investment and Buyer Leadership Forum is tackling one of the themes that, as you know, we care deeply about on this show. How do we build resilient health supply chains? How do we localize manufacturing? How do we create strategic partnerships, wink, wink, that strengthen healthcare delivery across West Africa? That's a very By Africa, for Africa theme. We're going to be on the ground at WHX, bringing you live interactive content straight from the floor, interviews with key leaders, behind the scenes conversations, and the kind of insights that you won't get just from the press release. So we can't wait to bring that energy to our listeners, and stay tuned for our WHX coverage. And if you're attending, come find us. I know
and if you're attending
yes, so we'll find you.
Please find us, because we have been partners to WHX, formerly Informa, over the last 10 years. I'm bringing together public and private. So we run their leadership summit, and it's usually very interesting. This year, we're going to have 2 directors from the Africa CDC.
Wow.
As you know, the whole talk now is about Africa's health, security, and sovereignty. So I think it's important that we are all aligned. So I'm even surprised that you are, aligning with WHX. So it shows that all the lines somehow are coming together.
All the lines are crossing. I love it.
Yes,
I love it.
Exciting.
Very By Africa, for Africa.
Yes.
I must find those directors. We'll find a way. We'll find a way to get maybe a few thoughts from them. But now, as always, before we jump into our conversation today, I wanted to take a couple of minutes to appropriately set the stage and outline some of the key signals in the landscape around public-private partnerships, the private healthcare sector in Nigeria, health financing, and just all the things that would frame our conversation today. Njide, I invite you to interrupt me, to jump in, to add some color to all the things that I'm saying. But we'll go through a few themes around the context and the landscape. So the first thing I wanted to touch on is the state of healthcare delivery in Nigeria. So challenges, but also the momentum that we are seeing. So let's start with the challenge. Nigeria's health system has historically been underfunded. Government health expenditure hovers around 3 to 5% of the national budget, which is well below that 15% target that was set by the Abuja Declaration. Out-of-pocket spending accounts for over 70% of total expenditure on healthcare, which places an enormous financial pressure on the households, on the average Nigerian. In October last year, the Nigerian Association of Resident Doctors flagged that the actual doctor-to-patient ratio stands roughly at 1 doctor per over 9,000 people.
That's correct. And getting worse because doctors are still leaving.
Japa is still a thing. And that's almost 10 times below what the WHO recommends of 1 per 1,000.
That's correct.
So WHO recommends 1 per 1,000 and we're at 1 per 9,000. Over 9,000. The number is actually 9,000 and something. Yeah. So that's something that really serves as a limiting factor to how we can deliver healthcare in the country. But there are real signs of momentum. I actually attended the HFN 2026 conference. It was amazing. I shared some of my thoughts on LinkedIn. But it was revealed on the public sector roundtable where we had the state commissioners for health for Lagos State, Ogun State. We had representatives from Algon. And the the State Governors Forum. Yeah. And it was revealed on that panel that 9 states have actually hit that 15% Abuja Declaration target. So while federally or as a whole, we're out 3 to 5%, there are actually 9 states in Nigeria that have actually hit 15% of their state budget on healthcare. Ogun State is primed to join that list. I think the health commissioner, Dr. Tomi Koka, for Ogun State mentioned that they're around 13%. So they're inching closer and closer. And in May 2022, the National Health Insurance Authority Act was signed into law, and that replaces the old NHIS and is making health insurance mandatory for all Nigerians and legal residents for the first time. And this was a landmark shift from a voluntary scheme that had failed to enroll more than 10% of the population to now it's mandatory. There's real enforcement kind of going on. And states are starting to act on it. So in that same that panel, it's probably on your website somewhere. Can we listen back?
Yes.
I would implore everyone to please go back and listen to that panel because at that panel, the Health Commissioner for Lagos State, Professor Abayomi, announced that Lagos State is the first to move toward actually mandating and actively enforcing compliance with the NHIA Act. And that means if you live in Lagos, if you're a resident of Lagos, very soon or already, it is mandatory. And the government is ensuring that everyone has access to health insurance throughout the state. And that's significant because Lagos being huge, when Lagos moves, other states tend to follow just because of their sheer size and influence. And I believe you are involved in that mandatory health insurance, working with the Lagos state government as well.
We're supporting and also, trying to collaborate because it's not really just about enforcement. You have to be sure that, the supply side is ready. And that's where we're working with LASHMA, which is the Lagos State Health Insurance Agency, to ensure that, there are hospitals that are good enough for people to visit if they ever fall sick. So I think it's the enforcement is just about to start. It hasn't started, but the word is that this year, 2026, it will start.
Yeah, and I think that's the beauty of public-private partnerships because on one side, the public sector has a mandate. They have a directive. It's signed into law and it's the opportunity to improve and expand health insurance coverage. But on the other side, the private sector has the technical expertise to raised the questions of let's make sure our facilities are ready. How do we kind of advance that? And when those two come together, that's when things fundamentally shift. And the private sector, like I mentioned, this includes hospitals, clinics, etc., even faith-based organizations, delivers an estimated 60 to 70% of healthcare services in Africa. And even according to the WHO, Nigeria actually has the highest proportion of care seeking in the private health sector in all of Africa. So for many Nigerians, we know the pharmacy, the patent medicine vendor, the private clinic is their first point of entry into the system when they fall ill. Correct. Some may view this as a gap in the system, but it is the system. Yeah. Like it quite frankly is the system. And I say this because the private sector is cross-cutting across the wealthy and the poor. Mm-hmm. So when we think private sector, we tend to think, oh, it's only for the richest of the rich or people who can afford it. But the WHO actually noted that the private sector in Africa caters to all wealth quintiles. So when we say private sector, everyone has access to some private care. Yeah. So the private sector has managed to kind of, I think infiltrate is a poor word choice, but all across, the rich, the poor, the underserved, the rural, the low income, and most families rely on it. It's
basically about trust. Mm-hmm. Who do you trust? You know, so if you're rich, you still go to who you trust. If you're poor, you still go to who you trust. Yeah. So there may be different strata of clinics or health providers that they access, but it's still really about trust.
Yeah. And that's a conversation we are going to have in this episode. Like, how do we build that trust? Mm-hmm. There's certain things that, have happened in the past year that really put that spotlight on how do we build trust in the healthcare system. Yep. But now we'll jump into the depth and the breadth of Nigeria's private healthcare system. When we say the private sector delivers healthcare in Nigeria, we're not just talking about one type of provider. We're talking about a huge, diverse ecosystem. So Nigeria has some of the largest private hospital groups in West Africa. We have companies like, Lagoon Hospitals, Nisa Premier, Reddington, etc. We have private HMOs, Hygieia, AXA, Total Health Trust, managing insurance for so many Nigerians. Diagnostic chains, we have Synlab, Serba Lancet, building that brick and mortar labs across the country. And then we have the pharmaceutical manufacturing sector, which we expanded on in our first ever episode with Charles Ogunwuyi, who's the CEO of Cygen. It's one of the largest in Africa. So we have over 100 registered manufacturers in our sub-region of ECOWAS. 60% of drug manufacturing takes place in Nigeria. The market is valued at around $4.5 billion, and it's growing. So homegrown companies like Emzor and Fitsin are expanding capacity and showing incredible profitability. And I think one fantastic example recently, the founder of Fitsin and his family are set to take home, I think, over $1 million in dividends following a standout 2025 that the performance was just underscoring the company's growing dominance on the Nigerian exchange group. I think their profits grew 125% from, I believe, 9.8 billion to 109 billion. Like it's just showing the potential in the private healthcare sector in Nigeria. And then we have the health tech ecosystem. It's among one of the most active on the continent. So health tech is our third largest startup sector in the country by startup count. So we're behind fintech and e-commerce. We have companies like Helium Health, which raised a $30 million Series B in 2023. That was the second largest ever for an African health tech company. And they've digitized over 3 million patient records across 8 countries. And across Africa in 2025, health tech raised $215 million in equity funding, which represented an over 200% increase from the previous years. So when we talk about the private sector in Nigerian healthcare, we're talking about everything from a community pharmacy in a rural state in northern Nigeria to a biotech startup in Yaba to a cancer center in Lekki. Like, it's everything. And the question is just how do we connect all of that energy and capacity and capital from the private sector to the public sector that needs a lot of this technical expertise, needs a lot of this energy, a lot of this capacity. And then the last point that I'll raise, which we'll expand on, is obviously PPPs, public-private partnerships. They have been a fixture in Nigerian health policy conversations for years. Like I said, everyone agrees they matter. There's no debate. But the honest truth is that most have remained at the tertiary level or as one-off projects rather than these scalable system-wide models. That said, we have seen some very meaningful proof points. PharmAccess developed the Access to Finance scheme, which is a PPP model designed to revitalize rundown government primary healthcare centers. And they do this by bringing in the private sector operators, backing this up by low interest loans, from the Medical Credit Fund and the Bank of Industry, bundled with Safe Care to actually, like you said, government has a mandate, but we need to make sure that the quality of the facilities is up to that mandate. And this model has been deployed in Delta State, in Lagos State, with remarkable results, including, and again, I referenced the panel from the HFN conference. This means you need to go and listen to it. This third time's the charm. Remarkable results. I think it was the representative from the Association of Local Governments of Nigeria, ALGON, that mentioned that such a PPP occurred, and through a structured model, 15 facilities were operationalized. And then we saw 0 maternal deaths over a 5-year period in those remote primary healthcare facilities. So it just touches on the sheer need for these things to work and to scale. So that's the landscape. I don't want to talk
done
everybody's
a lot of research. I'm impressed.
Yes, thank you. We pride ourselves on coming in informed so that not only our audience kind of has enough context to follow on in our conversation, but also for us to really be aware of the context in which we're speaking of. You live it on a day-to-day basis.
I'm impressed. Very comprehensive.
Thank you. Thank you. So we're going to unpack a lot of this today because a private sector that is already carrying the bulk of the weight, growing in scale, growing in sophistication, and a public system that is stretched thin, but beginning to put the right legislative frameworks in place. The question is, how do we combine? How do we bring both together? How do we build the structures, the trust, the incentives to make private sector involvement count at scale? So the question is not, is it possible? The question is, it is possible, but how? And how do we make that scale? So that's exactly what we're going to be unpacking today. I say all of this context and background, but I actually want to start with you and your journey. Njide, you've spent over 25 years in healthcare leadership, not just in Nigeria, but in the US as well. You've worked as a consultant, you're leading PharmAccess in Nigeria. Now you lead the biggest private sector healthcare coalition in the country. I want you to take us back. What drew you to healthcare in the first place? And how did your path lead you to this intersection of private and public, especially because I need all our viewers to know you studied computer science for your undergraduate degree, which seems quite far off from what you're doing today. And I think that's a fascinating trajectory in itself. So I'd love you to just talk us through your journey of where you started and how you got here today.
So it's been a really interesting journey for me. I come from a family of medical people. I have 6 siblings, and 5 of them have PhDs in pharmacy, and 1 is a medical doctor. Initially, I looked at how long they were spending in school and the size of the books they were reading, and like, nowhere on earth. So I went the opposite way to computer science. But very quickly, working in the United States, I found myself working for startup HMOs. I started out with AmeriHealth, then progressed to Independence Blue Cross in Philadelphia, then Cigna Insurance. And that was when it all started making sense to me. I started connecting my computer science background with systems. The fact that healthcare is really all about systems, architecture, data flow, process flow, interoperability, and trust, because one without the other, it doesn't matter how talented you are, especially in the healthcare system, it breaks down. So that was really how I started. I moved back to Nigeria in 2003. And my initial foray was with one of the largest HMOs. I was a consultant to them. But there was an interesting dynamic. My father, who at the time lived in Enugu, was extremely ill. In fact, I crossed paths. Once I arrived in Nigeria, I went to see him within 2 days, and he was actually, bloated. He was being treated for cough. So by the time I relayed this to my siblings in the US, they were like, okay, let's get him on a plane. And, so we flew him out to Houston. It turns out he had a kidney failure.
Oh, wow.
And he
being
never
treated for cough.
And he was, because his body was retaining water. Probably affecting his lungs, and he was coughing. So the treatment was so he was misdiagnosed. So of course he left with my mom, who just took a handbag and off they went to Houston. They never made it back to Nigeria. But at least they got 10 years of life because they had to go on dialysis 3 times a week and so on and so forth. But it kind of got me thinking, really. I mean, at that age, having served the Nigerian government for many years, because it was a civil servant, when a civil servant was really a civil servant. And then he's stuck in the US because he doesn't trust the healthcare system that initially misdiagnosed him. So, that also propelled me, what can I do to help the system here? Aside from, all the work that we do, trying to build structures and so on, but a system that I myself can access. I don't want to go back and live in the US in my old age. I want to be here around my friends and family, places I'm familiar with. So that, for me, that was a lesson and a turning point, that actually the passion that drives me today is, how can I create a system that I can also utilize, that is fit for purpose, no matter how, whether I start in a small community and scale it, but really, that is really my passion. So for me, computer science is really the backbone. Because it helps me see it from a bigger picture, the connectivity, the fact that it's a system. It's not just a hospital doctor focused or pharmacy focused, but really interconnected ecosystem that, trust must be the currency, and it must be anchored on digital technology. So for me, that's where my computer science comes into play. Without the data, you can't improve the system. You don't know what you're measuring, and so on and so forth. So for me, that's really the connection, how, I'm navigating this. And by the way, people keep calling me Dr. Ndili. I'm not a doctor.
At the conference,
yes.
I heard like 5 people call you doctor.
And I keep correcting them. And now it's against the
at
law.
This point, you might as well be. You've been in the healthcare space for how long?
For a long time. But now it's against the law. The Minister of Education just said, yes, you cannot, except you have a PhD.
You can't be called doctor.
You can't be called doctor. So I'm saying this out to everybody. Please don't put me in jail.
This is a disclaimer.
Don't put me in jail.
Interesting. I did not know that.
Yes, it was just proclaimed maybe a couple of days ago.
Oh, wow.
That use doctor in your name except you have a PhD.
Oh, wow. Okay.
I'm not about to get a PhD.
We'll be very careful. But it's interesting you mentioned the move from the US back to Nigeria and the parallel move of your parents to the US. I'm curious, what did you see first in the Nigerian healthcare landscape that made you feel like this is where I need to be? And also, what lessons did you bring from the US landscape into the Nigerian landscape? Not just, it works so well in the US, but what doesn't work that we shouldn't replicate, and what works that maybe you see, being appropriate for our landscape?
So, first of all, you have to look at the two systems as one well-resourced and the other not very well-resourced. I mean, even though we call ourselves resource-restricted, there's still a lot of resources in Nigeria. But the US taught me quite a number of lessons. One is that the payment system, the financial system actually drives behavior of the system. What that means is how you reimburse, how the payments are structured, actually drives how care is provided. So a typical example is, in the fact that you have insurance in the US.
Yeah.
It enables people to seek care when they need it. But at the same time, it also, influences the way providers bill, for example.
Yeah.
So it has its ups and downs. So on the one hand, that is well-resourced doesn't mean it's very efficient.
Yeah.
But bottom line is that the way the system is structured and the payment flow determines the way care is delivered, is accessed, the quality, and so on.
Yeah.
So it's very important to look at the healthcare sector as a system with multiple stakeholders that must work together to ensure that, the patient is at the center and, revolves around the patient. So that's on the one hand. On the side of Nigeria, for me, I thought, a country of 220 million people, of which I wasn't counted, nor was my husband. I mean, and yet you can't really trust that you will go into a hospital and get the quality of care that you need because there's no transparency. We're still paying out of pocket. People are not even trusting the hospitals per se. There's a public, there's a private. So how can you intervene? How can you make this, a system that can show transparency? You're able to benchmark between a hospital in Victoria Island and a hospital in Oshodi. What are the, how can you compare apples to apples? Systems, people, processes, equipment, so that in and of itself is where we need to start. That was the gap I was seeing. And luckily for me, I started out with helping one HMO. I would try not to mention any names. To structure their systems, their processes, because it was at the time when the national health insurance schemes were being rolled out. And I know for a fact from my own background in the US where, very easily, Cigna, Independence Blue Cross is covering 10 million people,
huge,
multiple fee schedules, different types of plans, coordination of benefits. So the systems are actually quite complex. Then you come back to Nigeria where it's paper-based. HMO has maybe at the time, maybe 50,000 lives, but yet there's one doctor who is looking at the claims and approving it. So shifting that mindset to be ready for inflow of enrollees and patients required a structured system approach. So defining processes, being able to, lay it on technology, being able to train people to recognize the codes, coding methodology, what are you using, so that way you're able to automate, auto-adjudicate. These are the baseline, really, for a system, for it to be automated, for it to be transparent, for it to be efficient, predictable. So these are some of the things I saw. For me, it was exciting because I bring back all the knowledge and I have to try and retrofit it into our context where the infrastructure is shaky. The knowledge is also shaky. The people don't know their rights, because, there's quite some huge gaps. So for me, this was an environment where I could deploy quite a lot of what I'd learned in the US. And I've been doing that since I returned. Yeah.
I'm seeing how your computer science degree would have been incredibly helpful. And I also like the point that you raised about the way that the payment systems are designed will influence the patterns in which people seek or deliver care. Because so I've spent a lot of my career in advising in the US system.
Okay.
And advising pharma companies on how to launch their drugs, how to get reimbursed by the Cignas of the world, the BCBS of the world.
Okay.
And we're seeing how a lot of pharma companies are now, their pipelines are going into the most innovative types of drugs you've ever seen, like gene therapies. You take one injection and you're cured of a genetic disease. Cured. We can't really determine cures yet, but virtually cured. But they're pricing it at like 3 million per dose, 4 million per dose. And when it was just one for like a really orphan, like very rare disease product or disease area, it was like, okay, we could stomach this for, the one child out of 500,000, that's not going to affect our bottom line in a significant way on a regular basis. But then every pharma company started launching 2 million, 3 million here, 4 million there. So now they're having to redesign the systems of like, how do we even design our benefits package? Like we might have to carve this out as its own benefit package at a higher cost. And then I juxtapose that with, we had a conversation with Dr. Nato in our last season. So he's the founder of Wella Health. They do microinsurance. And he was talking about how Nigerians, the way they seek care, they pay for curative care. They don't want to pay for preventive care because there's no system that's scaled enough to cover that care. So they only want to spend when it's a curative procedure. So he crunched the numbers and he was like, the vast majority of spending, out-of-pocket spending, goes to curatives. They come and they say, give me medicine.
Yes.
Give me something to cure this headache. Give me something to take. And even if you may not even need a pill, there's something about receiving a pill and paying for, yes, I paid for this medication, that Nigerians just trust, you know?
That's our experience, really. And the definition of patient satisfaction varies. We found very quickly that some of our implementation, that the number of drugs you give a patient, makes you a very good doctor.
Yeah.
But really, do they really need all those drugs? So what the patients describe as quality care may not really be
actual quality care.
So this is where behavioral change needs to happen, provide enrollee education, patient education. And a lot of that falls under the preventive, where they need to be aware. But I must say that things have changed, because we did a lot of work back maybe about 10 years ago around that, changing behavior, changing even the doctor's prescribing behavior and so on. And we've come a long way. I can say that things are changing. I think people are now a little bit more aware. So it's very important.
Yeah. And I'd love to then talk about the private sector reality. So we set the stage earlier with that striking statistic that the private sector delivers up to 70% of healthcare in Nigeria. And for a sector that carries so much weight, it often feels like it has to fight an uphill battle in policy conversations. And so as someone who leads the federation that represents these private sector providers, can you just help us understand the composition of Nigeria's private healthcare sector? So who are the players? What do they look like? What are their biggest challenges? when we say private sector, people might picture one large hospital chain. But what does the typical private healthcare provider in Nigeria actually look like? How many are SMEs, sole proprietors, faith-based? There's a range, and I'd love you to paint.
No, you're quite right, and you're mentioning them. Majority of private providers are SMEs, and they are, in the rural areas, hard to reach areas. They are your mom and pop, chemists around the corner, patent medicine vendors, community pharmacies, maternity homes. And to be honest, even I don't know the number.
Yeah.
Because a lot of them are unseen. A lot of them are operating under the radar.
Yeah.
But really, that's where people go. That's where the communities go. That's where, they are trusted.
Yeah.
They are accessible.
Yeah.
They've been known for a while, in their community. So people just go there.
Yeah.
Whether they are providing the right kind of care is then the question we need to be asking.
Yeah.
So I think it's important that we don't overlook them, but rather, how do we begin to imagine a healthcare system or imagine the private sector as, that gap, as we will call it, where people, they are filling a gap that exists because people are not able to go to the bigger tertiary hospitals or what have you. They go to where they feel they can get care. So our role really is to ensure that we improve the quality of care where people are going. And I'll come to that later because that's really PharmAccess's view in terms of, how do we ensure that the informal sector and the fragmentation of the healthcare system, especially around the private providers, is, we create a system that is workable to improve their quality, to enable them, kind of go step by step to improve the care that they deliver. I must add this, that a friend of mine who's a renowned medical doctor, currently owns about 4 clinics or running 4 clinics in Nigeria. His father was killed by a patent medicine vendor who gave him an injection, and it was an overdose of the medication he was supposed. Yes. So, and this is in the rural area because that was the closest to him. He went there, and by the time, the son went over there, show me what you gave him, and they realized that it was an overdose.
Oh my gosh.
Right? So the point is, don't neglect those guys. But how do you create a referral pathway? How do you equip them with the tools and the knowledge and the skills and the connectivity so that they can refer or they can, there's a referral linkage to a better system. That's what we need to think about, and not about shutting them down because they're not licensed and so on and so forth. So that's one thing. But coming back to the issue of challenges for the private sector providers, of course, there are many. One, and the most important one, is the power situation. Power is so integral to healthcare. Healthcare is very power intensive. And if you don't have power, then what are you doing? Your water, maybe there's a water pump, the power for surgery and so on.
Even this morning, I'm looking at TikTok where the executive assistant, we got here and there was no light. And all of these, this is a microcosm of what a hospital would even need. All of these need lights, these mics, these lights, everything. So we were outside, getting to pump the diesel into the generator and turn the switch. And
these are basic infrastructure that needs to power the healthcare system. By the way, I wrote an op-ed. We have a partnership with Business Day to write op-eds.
I dug into a few of those.
Yes, to write op-eds about issues in the private health sector space, but also proffering solutions. So we're not there complaining, but
I
actually
love that.
giving solutions of what could be done, mini grids that, you can have in an area where other providers can tap into, and maybe non-healthcare providers can also tap into. So power is one major one, so that we stop doing surgeries with your phone touchlight. Two is the jackpot syndrome, the fact that we're losing staff, and we're losing staff not because they don't want to stay in Nigeria, but because the conditions around which they provide care or they want to operate, sometimes it's not there. And then, of course, you talk about their family economic situation and so on. So for me, as PharmAccess, in the last 3 years, I think I've lost about 12 doctors to Canada. So you see talented workforce migrating. So private sector, you're seeing a turnover of staff. And that is actually financially burdensome because you have to keep retraining. There's very little continuity. So that's another problem. Third problem is financial. If there was a way to reward in a structured way, reliability of finance, So, for example, insurance systems, national health insurance schemes, how do you pay providers on time so that they're able to run their practices, efficiently? But even for those paying out of pocket, which is also a problem because oftentimes you hear about patients being held hostage because they're owing. And so these are just some of the issues. Then regulation, sometimes, regulation can be complicated and complex, especially when it comes to manufacturing, pharmaceutical manufacturing, and so on. So that all these problems, really affects the ability of a private provider to operate at their peak. Because you're working in a very constrained environment and trying to do your best. So I would say, the challenges are a lot, and they are not going away. In fact, last year, the Guild of Medical Directors mentioned that about 40% of the private facilities have closed because, either, they just couldn't keep up with the operation and the cost of operations.
And there's SMEs majority.
The SMEs. So these are some of the challenges that private sector is facing. So for us is how do we align the problems, how do we align our voices, how do we advocate? And that's really where HFN comes in, because we're now trying to aggregate all the different voices, because we're stronger together instead of each association going and meeting the same regulators and saying, can you do this for me? Or even access to finance. How do financial institutions understand and give funding or loans to the banks, oftentimes to the hospitals or private sector providers, oftentimes is at ridiculous interest rates. So there's a lot of factors affecting the private health sector, but they remain resilient and pushing forward. So that's why I'm trying my best, at least while I have the leadership of Healthcare Federation, to push forward, advocate, make sure I'm in the room, and highlight some of the problems that they have come up with.
And I actually want to spend a moment on the efforts of HFN, because you mentioned, you've painted a picture of what the private sector looks like. You've painted a picture of the challenges that the private sector providers face. And you noted that there's this advocacy that needs to happen, this joint voice of advocacy. And I want to spend a moment on a recent policy win for HFN that I think deserves all the attention, all the alarm bells should be ringing. So for listeners who may not know, APIs, so I'm just going to define the thing so that I can contextualize the sheer scale of this win in policy. An API is an active pharmaceutical ingredient. It's like the core chemical compound that makes medicines work. So paracetamol is an API, ibuprofen is an API. The raw materials for every drug. Nigeria and a lot of Africa, not just Nigeria, imports the vast majority of its APIs from India, China, you name it. And the taxes and duties on these imports, because when you import goods, there's usually taxes and import duties that are applied on that. So fees, basically, that you have to pay, directly inflate the cost of the locally manufactured medicines that come from these imported APIs. So as much as we're seeing that ramp up of local manufacturing on the continent, the sheer fact that a lot of the APIs are imported and these import duties are placed on them means that that cost inevitably is passed on to the final price of a medicine. So when a Nigerian pharmaceutical company wants to produce an affordable drug locally, they're immediately at a cost advantage because of what it costs to even bring in the raw materials. But, and this is a very big but, HFN began these high-level engagements with the Nigerian customs in June of 2024.
Yes.
Building on advocacy that actually started in 2022 because there was a paper submitted to the Federal Ministry of Finance.
Yes.
Well, finance, budgets, and national planning. And over time, the effort brought together a broad coalition. So there was the PVAC, so Presidential Initiative for Unlocking Healthcare Value Chain, the Federal Ministries of Health and Finance, the Nigeria Sovereign Investment Authority, and the Nigeria representatives of overseas pharmaceutical manufacturers. And this coalition together worked to define what the framework for actually implementing this sort of policy would be, identifying the eligible companies, and outline which pharmaceutical inputs, so which APIs would be covered. And as a result, there was a 2-year, or there is now a 2-year import duty and VAT waiver, i.e. the fees are waived on pharmaceutical raw materials. And that was implemented by Nigerian Customs in early 2025?
Yes, early 2025. Yeah.
I saw that and I was like, this is amazing. I would love you to walk us through that journey of what did the advocacy strategy look like in practice? Like, how did you build? Because we just talked about the challenges faced, but I would love to deep dive on how you've actually solved some of those challenges through this coalition, through this advocacy.
So it was a collective effort, first of all.
Yeah.
I recall that the prior president of the Healthcare Federation, Dr. Pamela Ajayi, and a few of us were invited even before the current president was elected into office to help write a strategy, define, what could be done in the healthcare sector as part of the manifesto. So it started from that. But also the fact that we normally bring our members together to tell us what their pain points are. That is actually what defines what we work on, what our advocacy would focus on.
Yeah.
What we bring together the leaders, because a lot of them are associations. So we bring together the leaders of the association, and then each makes a presentation. Sometimes we have maybe the chair of the health forum in the National Assembly sitting, so that the policymakers can hear directly.
I'd love to be a fly on the wall.
Yeah. Then after that, we follow up. We like to write position papers so that we understood very quickly that for government, you have to leave something behind. So it's not about talking. Document it, justify it, and what is your ask? Very important.
Yeah.
So so this bubbled up,
the
fact that all the APIs are imported. Sometimes a slap duty of 70%, 40%. All sorts of
steep.
Very steep. In fact, aside from the APIs, for example, somebody complained about bringing in theater lights, and they were charged almost 60% import duty, classifying it as a chandelier, So yes, somebody brought in an ambulance. It was duty, it was classified as a luxury car. So we
Wow.
were finding there were all these misclassifications. So first of all, we wrote a position paper. We submitted it to the Ministry of Health. But as we started engaging with Ministry of Health, we realized that, it's much more than that.
Yeah.
For VAT and for import duties, it's custom. So we went to custom, and custom says, well, we get a directive from Ministry of Finance.
Interesting.
So, that we were finding out as we went along that there's a lot of interministerial agency decisions that needed to be made. So we started working that pathway. Luckily for us, or because of the pressure we were putting, because we were always flying to Abuja, having all these meetings, they were listening to us. We made a presentation. We brought customs closer. And the last Honorable Minister of Health, Dr. Lausa, was actually very helpful to us, because he literally brought the Comptroller General of Customs into HFN conference and had him sit and there declared that he was going to give us a desk within customs so that we could then relate directly with customs. But anyway, having said that, this was flagged. We then had to we found out that there were a lot of other people, agencies that needed to be involved. And then PVAC was established, So NSIA also got involved. So, all of a sudden, to be honest, we initiated it, but at some point the ball started rolling. And, we just took a step back, because it was now between agencies and, having them iron out what the issues are. But ultimately, the result is the result. There was the waiver, and it's actually trickling down to the costs of drugs being produced, because that waiver has made it cheaper, or at least removed a significant amount of cost from the API. So it's translating into the final cost of the drug and then to the patient. And, I dare say that the likes of Fitton,
we will see another $1 million dividends next year.
But then you don't say that too loudly, because they say, you're making all this profit. So, hey, it's supposed to translate to the patient. But at least we are seeing that companies are benefiting, which is very, very important. Now, I'm also in discussions with PVAC, because only a 2-year waiver, whether this needs to be extended and what. So there's a lot of analysis going on from their end. And we have an MOU with the PVAC also on how to advance these kinds of policies, not just for APIs, but in other areas, sectors, in the healthcare sector, to create efficiency in the value chain. So I must say it was a Herculean task, but I'm proud that we got it, or we were involved in getting it done. There are a lot of players that were also involved, like PMG-MAN, the Association of Pharmaceutical Manufacturers. So there were different stakeholders, like identifying who needs to benefit, identifying which API needs to, because not all the APIs that get the weight, so things like that, the granular detail of it. We were involved to some extent, but there were many actors or players that made sure that, we're seeing the results that we're seeing now.
Yeah, and I love what you said. When you engage with government, you have to leave something behind. I think that's a tactical and practical lesson that I myself can take, and also our listeners can take. But the second,
Make sure it's stamped received.
Yes.
Somebody received it.
Yeah, someone received it.
Because what we were told is that paper is what creates a file. And if you don't have a file in a government agency,
like a literal paper file.
Yeah. So once it's received, they have to open a file.
Yeah.
And that's when your case starts. So if you don't have any file, then you haven't made any complaints. There's nothing to show that you even visited.
Yeah.
So that was a learning point for us. So everywhere we go now, we prepare a position. But even if we've spoken to it already, but as we're leaving, we hand it over. Yeah. There's signed, received, evidence that you were there.
Yeah, that's why I love having these conversations, because that in and of itself is like a gold mine of advice.
Yeah.
I'm still just stuck on just the impact. I can't get over the impact of what this kind of policy will have, because a 70% line item on your like P&L can tank
Yeah.
a business opportunity for even the large to small, like
Yeah.
depending on, and we're not, pharma companies aren't just importing 2 kg of API. I mean, they're importing like large quantities.
Yeah.
So when you multiply that, it's a really big thing. And I think, part of my day job, I advise, global health companies about access to medicines in low and middle income countries. And one of our projects, we're advising a particular partner on how do we lower the cost of goods. And API cost, when you're looking at the stack of costs that ultimately lead to the transfer price or the actual price of a drug, it's huge, it's big. And there's also, and this is, a global company. So I can imagine the sheer impact of something like this for if it's in for an Emzor.
Yeah.
And even for the smaller pharmaceutical manufacturers, this is, and yes, like we said, it will be transferred over to the patients.
Yeah.
Patients will feel that when I go to the pharmacy or anything and I pick up maybe I have malaria or whatever, you feel that impact.
For sure.
It's gone from 20K to 15K, it's now gone to 10K. Like you can feel that impact. So,
but it's also important now. I don't know if you're aware, but there's this African Union declaration or policy now on sovereignty and security. So so the whole idea is about how can you produce all you need for your healthcare sector within your sovereign nation. So if you're telling me that, I need to produce all of my, all of my pharmaceuticals, there's a transition period, right? Before we even start to locally produce APIs, there has to be some transition from a transfer of technology, partners from, instead of manufacturing it out there, can they import the APIs and manufacture here before they transition locally? It borders on, I think the impact is huge and it still needs to be maintained, if I dare say that, at least for while we stabilize, because otherwise, we're going to go back to our old ways. So I think it's very important. It's a very important policy. And I really appreciate His Excellency the President, because it was very swift. Within, all this happened within 2 years of the start.
That's a
very short
timeline for this kind of
government.
policy. Yes, exactly. I think people maybe might see 2 years and say, it took 2 years, but some things can take.
The National Health Insurance Act, how long did it take? It was at least 15, 20 years when it was initially passed, but yet we're still here. So I think it's worthy of recognition.
Oh, for sure. I had to take a moment to just pause and talk about that. But that then, because that is it was bred from public-private partnership or collaboration to get to that policy. There's advocacy from the private sector and then champions from the public sector that then took it.
Exactly.
So that pivots us into actually touching on PPPs, public-private partnerships. Like I said, we use this term a lot. Everyone talks about it. Very few have made it work at scale and sustainably over a long period of time. But you have experience leading the design of PPPs, the implementation at PharmAccess. And we want to dig into what separates the partnerships that actually deliver results from the ones that maybe stay on paper, stay on a desk. And I want to spend some real time in this section because I think this is where our conversation gets the most valuable to our listeners. It's almost like peeking behind the curtain of PPPs. So I don't want to talk about them in the abstract. I want to talk through the actual mechanics of how these deals come together, where they they're strong, where they might break, what it takes to make it stick. So I'm going to present, we're going to do a case study. I'm going to do a few PharmAccess projects, and I would love for you to take us behind the scenes, pull back the curtain, and just walk us through. So the first project is supporting Lagos State's mandatory health insurance rollout. Lagos State, the most populous state in Nigeria, I think the population has surpassed 24, maybe approaching 25 million people, is the first state to move toward mandating and enforcing compliance with the NHIA Act. PharmAccess has been technically assisting that rollout of the state's mandatory health insurance scheme, using the CarePay platform, enrollment processes, administration. I would love you to talk us through PharmAccess's role in this. How did the partnership with Lagos State originate? How long did it take to get the concept, from concept to implementation? Professor Abayomi announced that Lagos is actively enforcing it now, or is moving to actively enforce. How is PharmAccess supporting that? So really pull back the curtain and show us the bones behind this partnership.
Okay, so this is our relationship with Lagos State has been phenomenal and over a period of time. And I'll pull back the curtain, starting where we originally started as PharmAccess, because there's a thread that runs through. PharmAccess came with a concept of that there's quality and access to quality healthcare really is in a paradigm, right? Anchored on several pillars. There's the demand side, the supply side, the governance, the behavioral change when it comes to patient, and anchored in the middle is the trust factor.
Yeah.
And anchored on digital technology, right? To create that transparency. But we felt that, in order to change a vicious cycle into a virtuous cycle, there needs to be trust infused. So how did all this start? The Netherlands, as you know, is a small country that produces, by the way, a lot of the food that is exported into the rest of the world. Yes. So they're well known for their technology around agro, food production.
Yeah.
And they're very well, they try to export their technology around food, but they also have a fantastic healthcare system. So PharmAccess is a technical assistance partner of the Kingdom of the Netherlands. So we are funded by the Dutch government.
Okay.
And it's what we do is really aid in fulfilling their aid to trade agenda, right? So the work that PharmAccess does with its funding is to support the healthcare system in Nigeria as well as other African countries by helping improve the way the system is designed. So we see ourselves as entrepreneurs. You can see me in so many different areas, but really if we implement, then we're better able to diagnose and figure out what the problem is. So in Lagos, we started because we wanted to, we said that for people to pay for healthcare, first of all, they have to trust the system.
Yeah.
But that people need to also be catalyzed or to motivated to pay for their healthcare system. But how do we show them what a good healthcare system needs to be? So we started by subsidizing healthcare premium in Lagos State market women. We just selected a small community of market women that had a leadership. Then it was your lodger that we were dealing with. And we were subsidizing their insurance by 90%. So you can pay, I think then it was like 200 naira for a whole year's insurance. So many years ago. But it was a learning process for us. How do people access care? What is their definition of care or patient satisfaction and so on? So our findings from that system, which we at some point had to shut down because it wasn't really, we got the results that we needed.
Yeah.
Was then what informed the fact that health insurance in Nigeria doesn't need to be voluntary. It has to be mandatory, because that was a voluntary scheme. If you remember, the National Health Insurance Act before
was
not wasn't mandatory. So it has to be mandatory so you don't have adverse selection. And at some point, we're delivering over 100 babies a month in Lagos State from the cohort of enrollees.
Yes.
So you could see the adverse selection. So it's no more insurance. It's now maybe a sickness fund or what have you.
Yeah.
Right? That's the first thing. The second thing is that you have to enroll families. So not just the pregnant woman, but the husband, the other siblings, so that you can spread risk. After all, insurance is risk pooling.
Yeah.
But most important is that on the supply side, you have to intervene, improve the quality in the hospital, so that when the patient go in, then they are happy with the care that they're given. Then that they would now want to pay for their own insurance by the time we remove the subsidy. But very quickly we learn that there is a cadre of people that have to make a choice between eating, sending their children to school, going to the hospital, and so forth. And that's actually what gave birth to the Equity Fund of the federal government. The fact that there's a band of people that the government has a responsibility to pay their premium. So that's really how we started. And Lagos was the first one to pass a health insurance bill into law. Adopting health insurance, the fact that you have to prepay. Then we work with Lagos State to help design the benefit package. What goes into the benefit package? Actuarial analysis to determine the price, the benefit package price, the premium that will be paid. Working with the hospitals to improve the quality of care delivered. And that's where Safe Care was born. Safe Care is a quality improvement methodology that was developed by PharmAccess in South Africa, which is a quality accreditation agency, and Joint Commission International in the US for resource-restricted countries. So it's a stepwise approach to quality improvement. So for Lagos, we brought all our knowledge in because then it was a pilot. So we're designing it together with Lagos State, business process manual. We worked with HEFAMA at the time. When we were working with HEFAMA, it was just a desk within the Ministry of Health, but subsequently they moved out. We leveraged additional funding from different donors like Global Fund, FCDO, USAID at the time, to support Lagos. So we are the backbone that helped, put in structure around implementation of a mandatory health insurance scheme in Lagos State. So we continue to be their partner. For example, Lagos State Health Insurance Management Agency, LASHMA, is the first agency in the world, and it's been profiled by World Economic Forum, to incentivize providers based on their quality score.
Interesting.
And they're using Safe Care. So you can look that up because it's on the World Economic Forum.
I knew they were, but I didn't know it was the first in the world.
It's the first in the world. So the point now is that, can you use that as a model to encourage providers to improve quality of care? So there's a carrot that they can work towards. So our Safe Care levels go from level 1 to 5. So it's like a hotel rating system. So at least when you go to a level 1 clinic, you know what to expect. Go to a level 2 clinic, you know what to expect. So the whole idea is, if you're level 1 to 3, you get a certain reimbursement for your claims. Level, 1 to 2, then level 3 and 4, you get 30% more, and level 5, you get 50% more than those on level 1. Yes. So it is an incentive, but really, how do you ensure that providers continue to improve quality? Because quality is not stationary or stagnant. You have to keep working on it and improving. So these are just some of the things that, we try to embed within systems. And what we do is we as PharmAccess, we are not looking to be the continuous implementer. Like I said, we see ourselves as entrepreneurs or innovators, but we must have a local partner or an agency who we work alongside to ensure that there's scale, there's ownership, there's sustainability, and the likes around some of our innovations. So in Lagos, we're very proud of the work that they've done. Also in Delta State, by the way, Delta. Currently, I just saw the statistics released by the National Health Insurance Authority around enrollment by states, and Delta is number one. So they remain at the forefront, and I dare say that some of the successes is linked to the PPP that we did in primary healthcare level in Delta State, because it went from 0 encounters because the clinics were abandoned, the PACs were abandoned, to over 200,000 footfalls within the clinics.
Wow.
Over a period of time. And as you mentioned, 0 maternal mortality, even infant mortality, the numbers that we were recording were shocking. So it gave us evidence to be able to make a case for PPP or private sector involvement at the primary healthcare level. So, which is why we're currently also trying to engage with Algon to see how this can be replicated. I've made presentations to the Governors Forum. But again, what we are trying to work out is the payment system, because of course, private sector needs to be paid on time. And if the funding is with a government agency, then there are delays. And private sector, they have to have what I'll call consistency in the fund flow for them to be able to pre-plan and to run their operations efficiently. So yes, it's been an interesting journey supporting Lagos State especially. And I must say that Lagos State is unique in the sense that the people on the government side are very enlightened and very passionate. So it makes interaction easier. But then it's all about the speed of execution, the speed of implementation, as you call it, to make sure that it's sustained and scaled.
I have so many follow-ups. I will try and streamline them into 2. The first one is, you mentioned that it started off as a pilot. If you could summarize, what were the most important factors from transitioning from pilot to a wider scale with that PPP with the Lagos State government? I would love to understand that, because I think that's where a lot of PPPs go to die. After the pilot phase, it just dies a slow death. So I'd love to understand, what was the most important factor that pushed it from pilot to now it's something that's now kind of being widely implemented? That's my first follow-up. I'll reserve my second follow-up. I'll let you answer the first one. The second one is not related to that.
So the most important thing I must say is co-creation and ownership from day one. Oftentimes, donors and international organizations bring a cooked meal to the table. No. You want to make sure that you're co-creating, you're co-designing your priorities, and so that they take ownership from day one. That's how we've always worked, especially with Lagos State. So the transition is very easy. Because already you're doing the work. We're only supporting you. We're not the ones doing the work. So we tell you, this, that. Yes, we may bring some funding to tests, but it must be your ownership, your staff, so that's really how we've managed to keep it going and to scale it. And another aspect of it is, when we started this pilot, by the way, we started it simultaneously, Lagos and Kwara. We knew that because it was a new intervention, that we had to prove that is the right thing to do. So we backed it up by operations research and an impact which was published. The fact that this is the result of improved care, improved health because of insurance, and that it must be mandatory, so on and so forth. And we work together with the World Bank Health in Africa Initiative to help develop the policy, which was then passed at the National Council on Health.
Yeah.
As you know, the National Council on Health is the highest policy-making body. That is where, it was, kind of given a check mark.
Yeah.
That, okay, this makes sense. And then, maybe we need to pass a law. So initially started by the National Health Insurance Law Act. Then it transitioned to a state-supported health insurance scheme because we found that, when it's national, some states were complaining, we're remitting money to federal and our people are not getting covered. So it now devolved into a manageable state-supported health insurance scheme with some counterpart funding from the state. So that really informed sustainability.
Yeah.
You need to back it up by law. You need to back it up by specific pillars. So one is to ensure that you have a percentage of your consolidated revenue designated and put into an equity fund to cover those who cannot afford to pay. Lagos, unfortunately, has 69% based on the statistics. People living on less than, I think now $1 or $1.50 or $2 a day. But below the poverty line.
Yeah.
So it's a lot of people.
Yeah.
And where that becomes a problem is that the responsibility falls on the state to take care of those. But again, you can take it one step at a time.
Yeah.
In fact, we even developed a poverty mapping tool, which is PPI to Progress Out of Poverty Index, which kind of grades where you are in your poverty to know who should be fully covered, who should be subsidized, and so on. Otherwise, everybody becomes poor, and the state has to bear that burden. So enshrine it in law to make sure that it's when the regime transitions is still there. Two is ownership, to ensure that there are people within the government agencies that are co-creating and at the table when it's designed. So they're giving us input into the baseline of what really, they want, to back up, some of their own design. So it's not PharmAccess brought a solution to you. Third is, how do you structure the financing so that it's seamless? Oftentimes the barrier is not being able to get the money out on time. When it's in government coffers, there's a procurement process or however the money is released. You find that so how do you structure, the agency, build their capacity? We did a lot of capacity building. In fact, we have a healthcare management program at the Lagos Business School Enterprise Development Center, just focused on training both government and private sector owners how to run their operations as a business. It's not really, you don't have to be a for-profit to run properly, because you must be able to sustain yourself or at least break even to be sustainable. So those kinds of capacity building we did. So the DG of Alashma also passed through that program. In fact, the whole Health Service Commission sent the entire leadership to that program. So these are the kinds of interventions that help, ensure that there's transition, there's sustainability. In fact, right now, PharmAccess is not really supporting except on the supply side, because we're still working with Lashma on their building capacity of their assessors to maintain the safe care assessments and the program to ensure that quality continues to rise, even in the face of the moving personnel that are jackbarring. So so it's very intensive, very intensive, and we're doing this not just at the agency level, because we feel that the governance and the policymakers need to understand the ecosystem you don't understand, you can't really regulate properly.
Yeah.
So we work with HEFAMA, which is the Health Facilities Agency, regulatory agency. We worked with PCN, the Pharmacy Council of Nigeria. We worked with the Health Service Commission. We worked with LASHMA, as I mentioned. I mean, literally all the agencies, we had to, ensure that they're all aligned. And we don't forget, at the end of the day, the patient is the one in the middle.
Yeah.
So it's how do we see a system or build a system that is affordable, quality of care is good, accessible where they are.
Yeah.
Even at some point we had to do a GIS mapping to understand where all the facilities in Lagos State were and what is within those facilities, both the public and the private.
Yeah.
And where they're located, and juxtapose that around the population.
Yeah.
And look at where there are gaps in care provision, where there are no PHCs, and all that we had given to the Commissioner of Health at the time. So we've done a lot over the last I would say 12, 15 years with Lagos State.
Yeah.
But we're still not there. But it's a very difficult journey that we just have to keep going until we get it right.
Yeah.
Yeah.
Oh, every time you speak, I have 1,000 follow-ups. But I think I really enjoy the analogy of don't bring a cooked meal to the table in terms of co-creation. And we often have this term of the too many cooks in the kitchen. But for a PPP, it's really sounding like you actually need a lot of cooks in the kitchen, because I'm hearing a lot of interagency, stakeholder engagement and management that kind of drives a PPP. Because when you are coming from the private sector and, the public sector you want the public sector to implement a certain policy, it's like you've approached one sector within the public sector, one agency, but for that agency to accomplish that, they also liaise with another agency and then another. So it sounds like maybe that saying of too many cooks in the kitchen is actually in the affirmative, where within a PPP, it does sound like, because even with the import waiver for APIs, the number of different agencies that eventually had to all come together, it's super interesting. I
think that may actually be one of the biggest issues that people don't know about.
Yeah.
It's because our finding is that it doesn't just rest with one agency going to talk to the Ministry of Health or talking to the Health Insurance Agency.
Yeah.
I think it cuts beyond that. Another example I'll give you in another state where we were working is we actually helped. First of all, again, we helped to get the health insurance bill passed. We helped with the budgeting to determine how much should be put in the state budget to cover some of the activities that had been defined. And of course, nothing happened. So why is that? It turns out that the agency within the Ministry of Finance that was supposed to release the funding had no idea what that is. So they just overlooked it.
Oh, wow.
So all of a sudden it opened our eyes to the fact that Ministry of Finance needs to be, in the room with health.
Yeah.
In fact, they need to be Siamese twins, if I put it that way, because you appropriate and it doesn't get released.
Yeah.
We also had the statement from the current coordinating Minister of Health, Dr. Patti.
Yeah.
That his budget was it 216 billion and only 36 million was released.
It was like less than 1% released.
Yes. Yeah. So the point is, what is that process? What do you have to make a case to the Ministry of Finance? You have to justify. Yes, it's in the budget. That doesn't mean we're going to give you the money.
Yeah.
There must be a process. So how if they don't have a handshake?
Yeah.
We're going absolutely nowhere.
Yeah.
So that interministerial, especially with PPPs, by the way, I've never really seen a framework for PPPs. I mean, I know there's a ICRC at the federal level, but again, remember that health is on the concurrent list, as they say. So you're dealing with so many agencies and state. So federal is tertiary, secondary is state, local PHCs is local government now. So at each level, you're dealing with different stakeholders and different policies. That's why policy regularity is so critical to PPPs and their sustainability or their success. So it may work in one state, it may not work in another state. It worked in Delta State, it didn't quite work in Lagos State. So it's all around policies and clarity for the private sector. Private sector always wants clarity of regulation, consistency, assurance that if they invest, their money is not going down the drain when a new regime comes. So how do you ensure that there's consistency? Of course, the market. So there's certain factors. So if you want me to build a hospital, is there a policy that makes health insurance mandatory? Is it enforced? Are the people able to pay? And so on and so forth. So for the private sector, there's certain
boxes that
need to be checked before they can actually throw all their money in. And these are where alignment of incentives is so critical in PPPs. What does the government want? What does the private sector want? Is this structured in such a way that your incentives are being catered to? So,
Again, I go back to your analogy about you can't bring a cooked meal because it's like, it's going to sound so random. If you want to make effort with someone, some people like their effort really spicy. Some people like lots of palm oil. Some people like minimal oil. Some people like to add ugu. Some people do. Like, you have to come together and decide what are we putting in this effort?
Exactly.
Another example of a PPP, and you referenced it in Delta State, the revitalization of primary healthcare centers. This was through your Access to Finance scheme, where it's like a framework designed to encourage PPPs between state government and private healthcare providers to provide affordable and quality healthcare in government-owned facilities that are defunct, abandoned. There was a documentary on YouTube that I watched. I go into rabbit holes, but there was a documentary on the PharmAccess page on YouTube about this scheme. And I saw the video of the first visit to a PHC center. First of all, it was surrounded by
weed.
Yes, by just so much vegetation. And then inside, just pools of water and everything, ceiling leaking and stuff. And I was like, wow. Like, those are the government facilities that are then revitalized, and then at the end you kind of see the end product. It was pretty cool. But the idea is to kind of revitalize those types of facilities. So bringing in that private sector funding to then kind of allow that goal to be achieved, and also bringing in the government's insurance side of things. So you already mentioned Delta State. Again, pull back the curtain. How was this? Take us behind the scenes of how this happened. And in that documentary, there was a member of the PharmAccess team that was talking about needing to go to even community leaders within those local government areas to almost get them on board. You think, okay, so who doesn't want a PHC revitalized? But there's so many different stakeholders that come into the mix. So I'd love to pull back the curtain on that one as well.
Well, that was a very interesting one. And if I were to end my career, I would want to see that scale as my only, if I was to pick one thing that I want to accomplish in my career, it would be bringing private sector to run public PHCs. So in Delta, we were supporting, again, similar to what we did in Lagos, supporting their health insurance rollout. But very quickly, we found that you're asking people to sign up for mandatory health insurance and pay, but there's no clinic around them. Instead, there's a rundown old PHC. So, interestingly, the DG of the Delta Commission, Insurance Commission at the time, was also a forward-thinking person, Dr. Ben Nkechika. So we came to him and said, look, you don't have to spend your money. We will bring the money from Medical Credit Fund in partnership with Bank of Industry to give private sector funding to revitalize. Just give us the ones that are not that are run down, nobody is using. Just so that we don't have any issues with civil servants saying you took away my clinic. And that was what he did. He gave us some NDDC clinics, some that were quite run down, some as far out as 2 hours by speedboat into the creeks of the Niger Delta.
Wow.
And it was an eye-opener. What we said to him is that, look, we will bring in private operators who already have experience running hospitals. In fact, it was in partnership with the Healthcare Federation at the time. We put out a call for people to indicate interest of running a primary healthcare center. We selected about 6 private providers, most of who didn't even have hospitals in Delta State. Most of them were Lagos-based or Warri-based. And we gave them loans through the Medical Credit Fund and Bank of Industry to revitalize, on the premise that, one, there will be enrollees assigned to them from the mandatory health insurance scheme, even if they were indigents, that were being paid for by Delta State. 2 is that they will have safe care embedded within the clinics. And 3 is the fact that, they'll run the PHCs, and when it becomes profitable, they can split, the profits with the state. It was kind of build, operate, transfer, build, operate, manage. I forget the term. And that's how we started. So basically, some of them didn't even need revitalization. The ones that were in the creeks of the Niger Delta, 2 in particular, was being run by Dr. Eze, who is the owner of Toronto Hospital in Onitsha. And he used the oil industry 2 weeks on, 2 weeks off to move the medical crew. So 2 weeks on to manage a clinic that had actually been built and donated by Chevron 15 years ago.
Wow.
Everything was still intact, locked, nobody to operate. And then, they started operating. Fantastic results that we were seeing. People started, all of a sudden, the clinics were full. Pelham Memorial in Lagos here was running 2. Outreach Hospital in Lagos was running 1 or 2, I don't remember. SFH. These are experienced operators. And it takes you back to the model used in the US, where you have hospital systems, Kaiser Permanente, Christus St. Elizabeth, they run because it helps you manage your quality, helps you manage your purchasing, bulk purchasing, it helps you manage your personnel, so it's like a system, it's like a franchise system that helps you manage. So that was the whole idea behind that. How can we get experienced operators to come in, bring their expertise, their efficiency into a government-built PHC. And that was what we did. And the results, phenomenal. We have an impact evaluation that was done, which was also very revealing. Not only the fact there was 0 maternal mortality, there were some learnings too. For example, in the rural areas, pregnant women, they often have market days. They wait till I have to sell market. They wait till the end of the day before even though they're in labor, before they go to the hospital.
Wow.
So they usually end up in the hospital after dark. There's no light in the PHC. Then you can imagine what happens. But all of a sudden, because these are run by private sectors, 24-hour care. In fact, Shell, I think, donated solar panels. Good things were aggregating around those PPPs. All of a sudden, people were coming in. We were delivering babies to the extent that one of the providers said, look, we have to do some family planning. We have to do some family planning education here because the birth rate is so prolific and all that. But the fact that, there were specific anchors to the system, again, the fact that you had a committed leader in government who took ownership of the program. He wanted to make sure that it worked. 2 was a clear alignment of incentives. The private sector at the time were getting paid. the numbers were coming, they were supplying them or giving them enrollment basis. The patients were happy.
Yeah.
So all of a sudden you see a system that's working on the back of a mandatory health insurance scheme, where those who couldn't pay were being covered.
Yeah.
Not just through, I think they had a lottery fund, but also the basic healthcare provision fund.
Yeah.
You had quality embedded in the PHCs. We checked all the boxes.
Yeah.
But of course there were delays subsequently because for PharmAccess it was just a proof of concept.
Yeah.
The fact that this can be done is somebody now needs to take ownership. So we exited in terms of, stepping back at some point because we had done our impact evaluation. We had advocated at, the Governors Forum and different places. So it's now who is going to scale this?
Yeah.
What's the modality for scaling, and things like that. And I think some of those discussions are currently ongoing. But that's really how we came about that scheme. The fact that at the primary healthcare level, it's not that poor people or indigents don't know what quality is, but it's just that it has to be infused into the system for them to come. Or even some of them were even willing to prepay or pay for their care out of pocket, which we try to discourage. But how do we create that pathway, create transparency, efficiency? Government really doesn't have to be the one running. It saves you cost on your staffing. It saves you a cost on equipment and things like that. You don't really need all that. And something else I want to mention is the fact that through our impact evaluation we realized that the amount of money that was being channeled from government to those PHC was, even though it was a lot of money, like 1 million, 2 million a month, it was insignificant it didn't make a dent in terms of improving the overall efficiency. Do you understand? So you're putting money into a hole and you're not seeing the results. So you need to actually increase the quantum of funding made available to a PHC. And then for how long, if it's coming from government? Meanwhile, private sector can generate its own funding. There were, in fact, one of the PHCs, I saw where they were giving old people exercise lessons. There were about 30, so all of a sudden you create a community. They put power. So people are coming to charge their phones. Somebody was selling food.
Wow.
All of a sudden a PHC becomes a community center.
Wow.
So these are some of the ideas that private sector comes with. They don't have to they aggregate their problems, or they try to aggregate for efficiency. Bulk buying, what you do here, do it there. If I'm buying for this clinic, I buy for the other clinic. So it's almost a no-brainer. But somehow it remains extremely difficult. So we proved the case. We wrote an impact evaluation report. We made it available. It's even online. So what we're waiting for is how do we implement policy, or how do we scale this so that it's not in discussion. It's not sign an MOU ceremony, but rather execution. I think that's still the bridge we need to cross. In fact, at some point we brought in Lagos Business School to help when HFN visited the Governors Forum to help. What is it that is really stopping this fantastic framework from scaling?
And what did you find? Because one of my questions was going to be, how do you take this from 15 facilities to 150, to 1,500, to 15,000? What's that binding constraint?
So the constraint, twofold. One is, what would I call it? Money fund flows. Private sector needs to be paid on time. They need to, there has to be transparency around the funding. And sometimes, with government, they say, it went into a TSA account. Sometimes private sector doesn't get paid for up to 4 months, right? And they're not willing to take up any new ones. In fact, a lot of the private sector providers or operators started seeing this project as a CSR because they were running it on their own funds. So that was the one thing. What is the right structure for fund flow? Do you take that funding out of government? Can you have an independent agency that holds the insurance premiums so that they're better able to manage the scheme? That's still up for question, whether government will agree to that or not. So that was one main thing. Another thing was technology. The fact that transparency oftentimes wasn't very present. The fact that some of the clinics were so remote that, you had to do a lot of things online. So how do you ensure that there's that connectivity that creates a flow? In the beginning, I talked about the healthcare system being an ecosystem. There has to be transparency. There has to be data flows. There has to be transparent financial flows. There has to be connectivity. Everybody has to, if a patient goes here, it reflects somewhere. So that way the system is integrated. So that was lacking. So at some point there was, they're owing me. Did he come here? He didn't come. Questions around who are you treating? Who visited the hospital and when, and things like that. So it still remains a problem. And the third, I would say, is a bit controversial, but public sector is a bit territorial, right? We heard cases of government saying, the staff in the PAC say, no, you want to come and take my job. Private sector wants to come and take my role and, things like that. So you begin to wonder, how do you approach this? But I've always said you don't have to start with all of this. Just start with the ones that are non-functional. So again, these are some of the discussions that are ongoing with ALGON, which is Association of Local Government Chairmen. That all private sector can do is create your efficiency. Help you build your capacity, help you put in systems that will create efficiency. And if we replicated that model, really, you can take the funding you're getting from government and pay premium instead of upgrading the facilities. Really. And, we've had discussions with the likes of Africa Development Bank, where they were very interested in the Delta program because of the impact at the grassroots level. But unfortunately, entities like that are looking to give big money. $100 million, $50 million. But I will tell you that when we started, just to get one of those PHCs up and running didn't cost even 30 million. So there's small amounts of money that larger development finance banks are not willing to, they think it's too much work. They tell you, if I give you $10,000, it's the same amount of work I need to do if it was $100 million. So why would I waste my time on this small amount of money? So these are some of the challenges, really. But I think there's hope. There's a lot of work, a lot of opportunities. Because I'm sure that there's over 30,000 PHCs. Of which less than 30% are functional. And by the way, I even questioned those numbers because when we went into Delta State, there were PHCs that the government didn't even know existed. Constituency projects. When they saw what we were doing, said, "Oh, I have an abandoned PHC." We said, "No, we didn't see any abandoned PHC. So don't worry, I'll build one and abandon it." I mean, so things like that. So it may actually be more. Because the tendency is bricks and mortar infrastructure rather than systems that help enable access to care.
And I have, to conclude this section, I have a hard question. Nigeria is heading into an election cycle. And we've already seen what happens with PPPs that maybe, like I think there was a PPP maybe in Kwara State where it was praised by the UN Secretary General, but there were some disruptions when the political leadership changed. And how do you ensure this continuity when power is now changing hands, or we're gearing up for power to potentially change hands, or reshuffling of who's appointed to where, etc., and in this new kind of election cycle. So how do you prevent those initiatives from getting stalled during these transitions, or political cycles then impacting the continuity of PPPs?
Well, that's a difficult one because that's my lived experience. The only thing we thought to do is to ensure that there's policy backing, support the work that we do, so that it's difficult to wipe it away. What you talked about that was praised by the UN was actually a Aquara health insurance scheme. We at some point was the largest PPP insurance scheme in sub-Saharan Africa. Okay. But at some point we had to stop. Because we needed to make that transition to the new administration. In fact, for almost a year, we couldn't engage because they were trying to settle down. We didn't know who to talk to. Eventually, we identified a person who luckily was kept from the previous administration, so the scheme kept going. But it is the most difficult barrier that this kind of projects face. So to solve it is really a policy, or dealing with the institution itself. That is dealing with the agency, maybe not the top layer, but ensure that the next tier is involved and buy into the project that you're running. Because oftentimes the DG is removed, but the core civil servants remain. So to ensure, when I talked about co-creation, that they're involved and so on and so forth, that's the only way. But even then, it's still a very difficult challenge that we also don't quite have a solution for anyway. So again, it goes back to policy.
And we'll see, as we're going into an election cycle, I'm sure there's all sorts of, you even mentioned ongoing conversations about how to expand this program. I guess lived experience will tell, how things transition. Now I want to shift to something that sits underneath everything we've discussed, which is trust. You've referenced trust as being the currency between all the different stakeholders in PPPs. We've talked about, patients actually trusting the healthcare system. And quality has come up quite a lot. And as we say, the private sector is building the rails. And as part of that, has this intersection with a lot of different patient types, etc. I would love to talk through what PharmAccess has been working on. So PharmAccess has been working on this building of quality, building of trust through Safe Care, which brings internationally accredited quality standards to the African healthcare reality. Given this landscape where I would say trust in formal healthcare is fragile, but it's kind of a weird oxymoron, because a lot of Nigerians bypass formal healthcare and seek medicine from traditional healers, etc. So there's trust where there's no regulation, but where there's regulation, might not be as much trust. So I'm curious to hear about what Safe Care is doing and what Safe Care has been able to accomplish in the context of this landscape.
So this is where, PharmAccess has really made its mark in the healthcare sector. So Safe Care is a quality improvement methodology. I mentioned this several times. It is a set of standards that was developed by PharmAccess in collaboration with Joint Commission International, JCI, based out of the US, and COSASA, which is based out of South Africa. Pretty much to create a formal way to benchmark health facilities in resource-restricted countries or settings. Usually in the US, JCI, you passed or you failed, right? But what we're doing is trying to take these standards and localize them within our context, the African context, where it's practical. It focuses even on our culture, our behavior, the way the patients, see healthcare, where they seek healthcare. So it is incremental.
Mm-hmm.
It is in the local context.
Mm-hmm.
It is not for, even though it works in big hospitals, but it could also work, you can apply the standards to smaller settings. So we have levels 1 to 5.
Yeah.
The likes of Taylor Memorial is on level 5.
Mm-hmm.
And it applies both public and private, which is interesting because you can cut across any healthcare facility. So that way you're better able to benchmark.
Yeah.
And the focus is on, the skills, the equipment, infrastructure, and processes.
Yeah.
So the infection control, record keeping, ancillary services, there are certain domains that it covers. And what is interesting about it is that, it's not, okay, do you have a guideline to treat malaria? Check. Or do you have a stethoscope? But it also checks the functionality of when it comes to equipment. You have it's good, but is it working?
Yeah.
Do you have a maintenance agreement? Because if it's working and you don't have a maintenance agreement, when it breaks down, what happens?
Yeah.
So we try to give you a step-by-step approach and give you tools that will help you to improve quality.
Yeah.
Right? So we see it as a progression. And it's not punitive. Rather, we work with you. So the baseline is that we do a baseline assessment. That's what we call it. And from there, we give you a quality improvement plan, what we call QUIP. It tells you where all the gaps are in your facility and what you need to do, right? We also progress it to mentored assessment. So mentored assessment is where we can actually work with you to fix all those gaps.
Yeah.
Or you can decide you want to do it yourself.
Yeah.
But that way, you can move, you see progress, you see, you have an incentive to improve quality. We also now started putting some of the providers in community where they can communicate amongst themselves, so they can cross-learn. But it's been interesting because this is the first of its type that was accredited by ISQA. ISQA is the International Quality Accreditation Body. So they accredit the accreditors for resource-restricted countries. Now, I think there are a few more. And we are in over 27 countries, in over, I think, 10,000 clinics. In Nigeria alone, which is where we started, this is where the standard started, by the way, we have a lot of hospitals that are currently implementing. And I must say that we are the backbone of the National Health Insurance Authority. So SafeCare is being implemented and cascaded to the 7,000 BHCPF facilities. And we are training the NHIA staff to own it. So we try, in the past, we would do the assessments and work with you, but now we're trying to find partners that would help take it on, build capacity, and that's the only way we can scale. So it's important for us now because quality remains at the core, the center of us achieving universal health coverage. It's the arrowhead. If there's no trust in the system of the quality, then I don't think people will prepay for healthcare. And also what is good is the fact that we are taking it not just from the formal healthcare providers, we're taking it to the informal providers. So, where we have what we call pharmacy tools that we can deploy within pharmacies. We work with different associations and agencies to ensure that, our standards are fit for purpose and it's improving quality where the people are going. Where they're already going. How do we ensure, instead of, I'm shutting you down. You're not, but rather how do we work with them to ensure that they improve the quality, or we embed them and create a linkage into the healthcare system. Oftentimes what is happening in those providers is invisible. Nobody knows. So we're trying to make those linkages using digital tools, using training and advocacy to ensure that we're creating linkages into the formal healthcare system. Otherwise, nobody recognizes them.
And I'm curious, what is something that you have seen in terms of like a before and after that would bring this to life for our listeners, like taking a healthcare facility from level 1 to level 3 or 4 or 5? Like how is...
the biggest example I can give is FMC Ebutemeta. It's a government tertiary facility. We worked with them for 4 years. And, I myself, the only hospital I've been admitted in was in FMC Ebutemeta.
Really?
Yes. So this is a hospital that is now paperless. Wow. It's a hospital where the chief medical director that we worked with has even transitioned out, but the system still remained because of how we worked with them. When we started, there was a wedu in the vaccine fridge. The before and after is clear. And because of that, every minister of health that takes on that role visits FMC Ebutemeta as an example. Wow. And as a result of that, the Minister of State for Health has actually assigned 48 other tertiary hospitals to PharmAccess to work with to see how we can transition. Wow. And because it's now a center of excellence. To how can we replicate what we did in FMC Ebutemeta across 48 other tertiary facilities. So that is the biggest example. Wow. I always tell people, go there, look for yourself, see what we're doing. But again, it's not stagnant. It has to be maintained. Yes. So the proof is now going to be in how do they maintain the quality that we've embedded within the system. But that's just one example. But there are many more. And I'm curious, what is some of the biggest challenges with Nigerian healthcare facilities improving their quality? Because I want to believe that every person or medical doctor, whoever that starts a facility or builds a facility has the goal of providing quality care. Nobody, I hope, has a goal of providing substandard care. But there's obviously challenges that get in the way of that goal. So I'm curious, what exactly are those challenges? As you've seen the implementation of safe care throughout all these different facilities, what prevents hospitals from or facilities from improving their quality? So first of all, leadership counts, right? The medical director has to buy into the fact that he doesn't know everything and that he has to put in a system that puts guardrails around, his facility in terms of implementation. That includes the staff. The staff you hire, the systems you put in place. All this has really an impact on the ability to scale quality. But what is also more important is access to finance. The fact that, a lot of hospitals are still treating patients out of pocket. So except you have institutional funding, you're growing organically. The doctor is the receptionist, is the anesthesiologist, and it's really small SMEs, owner-founded facilities. So it puts a huge barrier. If there's no constant income stream from insurance or from out of pocket is subjective and it can fluctuate. But if there was constant income, then it can give you predictability around your operation. So I think that remains a big challenge. In fact, what we're seeing now is a lot of hospital closures from owner-founded, whose kids have jackpot. They don't want to run the hospitals, and then they're stuck. So there's an entity right now that is mopping up all those facilities and creating a hospital chain. Yes. Very interesting model as well. And I think it's one to promote. Their name is Care One. You can also look them up. And they're also part of HFN. They were also part of the access to finance in Delta. So I think that's what gave them the idea. So they're now taking it to the private sector side to aggregate those types of hospitals. And, so I think that's really what it is. Finance, staff retention, power. So some infrastructure foundation that makes it difficult to maintain the level of quality. Is expensive.
Yeah.
They have the right equipment to follow the right clinical protocols and do the right thing. When somebody comes in with a fever, you do the test first before, there's certain clinical protocols that you would follow. But, again, it's all about financing. We find a lot of our providers try to cut corners because the patient doesn't want to pay, So this has a vicious, generates a kind of vicious cycle, and it ultimately affects the quality of care that is delivered. So, and that's what we're trying to work around. So, for example, with safe care, when we say for infection control, that you must have running water. So it doesn't have to be that you have a borehole, and it can be a tank, but it has a tap so that when you open it, more water runs. Right? So how do we localize some of the solutions to fit within our context?
Yeah. And, now that we've talked through the landscape, the composition of the private sector, the realities of building PPPs on the ground, and now we've talked about trust, I want to pause and put you to the question that sits at the heart of every conversation on this podcast. What does it take to revolutionize the African healthcare business model? This is our blue sky question. More specifically for your world, when we think about PPPs in healthcare, we have decades of pilots, frameworks, MOUs. Some have worked, some have scaled, most haven't. What does it actually take to move from that partnership as a buzzword or pilots, several pilots, to partnerships as the operating model for healthcare delivery in Nigeria and across Africa? Blue sky.
Yeah. So first of all, we have to take away the notion that healthcare is a social benefit. It is an economic investment in any economy. So we have to start, shifting that mindset that health is a business. Right? If we start with health is a business, it will restructure the way we interact. That's the first thing. Second thing is that the private sector is not an afterthought. It has to be integrated. The likes of the banking sector, the power sector, all those were revolutionized because of private sector innovation, the new ideas that they brought in. When last did you write a check for a bank? In fact, when last did you walk into a bank? Everything is done online. What stops the health sector from thinking from that perspective? The DTH lab, which is Digital Transformation of Health Labs that I'm involved in, is looking at health as click and brick. In fact, we've developed a new framework of the healthcare system of the future. So it's a digital framework. Because maybe we don't need to even walk into a hospital to consult with a doctor. So it's really seeing the healthcare sector or space as one that needs a lot of innovation, allows the young people to come to the table. We have to be deliberate about creating space for them to come to the table and help us design the healthcare system of the future. Because, we're doing well in every other sector. Fintech, the young people are busy doing podcasts, they're doing all sorts of things. But when it comes to health, the young people are not seen. And we leave the system for analog leaders to design a healthcare system for the youth growing up in a digital world. So the young people need to step up, or we need to be deliberate about bringing them to the table. So that's another thing, because their ideas can actually help change the way healthcare is delivered. So that's another thing. The third is finances. How do we create a financing structure or allow finance to flow to healthcare? Because without the finance, it's not going to be sustainable. The fact that it's really a system that's anchored on finance, is anchored on people, talent and infrastructure, and they must work together. My background as a computer scientist tells me that, in a system, each component can be very good, but if they're not working together, it doesn't matter how good that one component is, it falls apart. And that's the way we need to start looking at it. So a system where the private sector is integrated, the people trust the system, there are digital innovative ways of accessing care, telemedicine, other ways, maybe some we don't even know about today. That is the healthcare and meeting people at their point of need. So it's not about the big hospitals, but how do we integrate the smaller informal healthcare providers into the system, right? Because really, you can't, in resource rich countries, they have big hospital systems here and there. I don't think they have all these birth homes and things like that. But this is our reality. So how do we make our reality work for us? So I think those are the themes we need to start thinking about. How do we utilize and create efficiency around what already exists instead of shutting down, penalizing, and removing them from the system where there's going to be a vacuum and it creates, a downward spiral for us, for our people.
So you've just painted a picture of the blue sky and what it takes to get there. You lead the Healthcare Federation of Nigeria as the president. And it's come up throughout this discussion of just the HFN being involved in so many different initiatives. And the HFN has spent a decade building a platform for the voice of the private sector in healthcare. HFN recently celebrated its 10th anniversary and outlined a very ambitious, forward-looking agenda. But now that you sit in the seat of the president of the HFN, what are the biggest priorities for the next decade? Like where do you want the HFN to go? What are the priorities? What are the goals to kind of make that vision that you just painted come to life, if we dare so say?
Yeah. So the vision is very clear. I had outlined a few things that I wanted to work on. Of course, you can't do everything because the timing is so short. But one is the PPP I talked about, especially at the primary healthcare level. If we can replicate that model, is something that I would love to do. We've already started all sorts of engagements, all sorts of discussions. But again, it's left to government to bring us in. So that's where the advocacy really is important, making sure that we're in the room. Two is local manufacturing and health sovereignty, which is why we have an MOU with PVAC, so that we can align. There's so many people working in silos, but if you want to talk to private sector, can you talk to us? Let's work with you to see how we can get this done. You saw what we accomplished with the API. Again, we are the voice. So the most important thing is aligning private sector because we're so fragmented. And if you watch or look through HFN social media handle, especially on LinkedIn, you see that I've been deliberately visiting and partnering with being actively involved in the different associations. Last week I was with the medical lab scientists because nobody talks about diagnostics and the issues, the reagents and so on and so forth. The other day I was with the nurses. The other day I was with the community pharmacists. So how do we're not competing amongst ourselves, but we are seen as a cohesive coalition of private sector who want the same things. So I think that's what really causes the problem because different people approach government for different issues and then they deal with just that person. The other person goes and we're so fragmented. So my job now is really how do we align? Last week also, was it 2 weeks ago, I was with NAFDAC again about regulation around local manufacturing and those that want to, start their own new manufacturing plants, things like that. So making sure that we are aligned is very important to me. So that's another goal. Another goal is data and leveraging technology, which is why I'm pushing really the DTH lab interoperability. Now, when you hear me talk, I'm talking about data. Can we have a data exchange where all that data goes through? When I was in the US, we had huge databases through which Medicare, Medicaid, all that run through. UK is the same thing. So can we have that kind of transparency or a data cooperative where, there's a ring fence around the data that enables ethical movement of the data with the patient's consent. That is very important. Because really, I think in the future, the consent has to lie with you and I. Don't take my data without my knowledge. So how do we begin to build that infrastructure? I think that's key, because without transparency, what are you really, how do you know who is accessing care? If there's improvement, you can't really know anything. It's all guesswork. So those are the main priorities for me, to ensure that, we really embed, private sector is not seen as an afterthought, but at the table, helping develop the policies that are enabling the private sector to grow and support government to achieve UHC. So those are some of the, things that we should really focus on. And it's really, there's a lot. So you have to prioritize, otherwise it's overwhelming. And dare I say that what I do for HFN is on a pro bono basis. I'm not, I'm doing it just because it needs to be done. And there's no agency right now that is doing what we're doing. So it's very important.
Very, I agree. We've covered a lot today, and for me, it's been such an insightful discussion. We always conclude with rapid fire questions. So it's a quick question, quick answer. We'll go through just 3 rapid fire questions.
Okay.
My first question is, if you had 50 billion naira to deploy into Nigeria's health system right now, where do you put it?
Definitely primary healthcare, because that's closest to the people. That's where they're going to access care. But I wouldn't say give it to government. I would say can private sector help you deploy that money, and that way, we can revitalize those PHCs because they're closest to the people.
And speaking of PHCs, what is the primary healthcare center you're most proud of revitalizing?
Well, I would say the Shonga Clinic in Kwara State. That's the first PHC I went into. And when I went in there, I went with then Minister of Health, I forget her name. When we went in there were goats running around. Goats. Yes. Pregnant goats. Those goats are always pregnant. Pregnant goats, grass everywhere. And within 2 months, the utilization went from 0 to over 5,000 a month.
Wow.
Yes. And that is really the start of the idea of a PPP, because it was in such a remote area, nobody wanted to go. So we brought in private sector, So that I'm most proud of it. And interesting, one of the ladies, young girls, actually, I must say, that the first baby that was delivered there, they called the baby Hygia. At the time, I was, the chief operating officer for Hygia when we started that program. The baby was called Hygia. It was so inspirational for me because, sometimes we do work and we don't see the impact of what we do. But when you come in contact with the lives that you're saving, then, it means a lot. It pushes you on to continue to do more.
And, outside of Hygia context, it's actually a really pretty name. Like, if you didn't know Hygia was an actual company, I feel like that would be a pretty name.
I think it's the goddess of health or something.
It's really
Greek
pretty, very beautiful. My last rapid fire, what gives you the most hope today?
What gives me the most hope is somehow I see the lines beginning to intersect. I see the government actually listening. The movement is small, but I feel there is movement. For example, private sector is now a signatory to the UHC compact that was signed by all the governors. Right? HFN was a signatory there. We were a signatory to the Power Compact that was signed by the government. We are now allowed to provide care under the Basic Healthcare Provision Fund, private sector. There's finance, available. It's just really now, how do we build capacity of private sector to be able to access that finance? There's a lot of discussion around the same themes, around the same, what do we do? The fact that health sovereignty, now people are looking in because of COVID. When we didn't get the vaccines, they realized, okay, now you're on your own. USAID gone. That means donor funding is out the window. So it's all about self-reliance. So finally, we have to look inwards to figure out how to solve this problem ourselves. So for me, that gives me hope, even though it's going to be a difficult period, but I think we're beginning to rewire our brains to know that nobody is coming to save us.
The safety net has kind of been ripped away.
So the sooner we start rethinking what can we do with the resources that we have, with the talent that we have, because we do have a lot of, how do we leverage the diaspora talent as well, and things like that. I think, it gives me a lot of hope. And of course, the young people. Everywhere I speak, I said, the young people, you are in the majority. Don't just sit back. Get involved. It's your system, your healthcare system of the future. So help design it. So I'm very hopeful, and hopefully in my lifetime, I will see a healthcare system that works.
Amen. Thank you for sharing your experience. Honestly, this has been a fantastic conversation. Thank you for talking about the work you're doing. For me, the key takeaway is Nigeria's private sector is the system already. It is providing the majority of healthcare. And the question is no longer, should the private sector be involved? The private sector is involved.
We're here.
And how do we push that forward? For our listeners, you can follow the Healthcare Federation of Nigeria and PharmAccess to see all of the amazing work that they are doing. And one more thing before we go, don't forget, The Cure will be live on the ground at the World Health Expo Lagos from the 2nd to the 4th of June at Landmark Center. We'll be bringing you conversations with some of the most important voices in West African healthcare right from the exhibition floor. See you in the next episode. Thank you, Njide.
Thank you very much for having me.
Of course.
It's been wonderful.
Bye.
Bye.